year, probably split up, and some of you stay in the success stories and others go to the marketing, development, product positioning session. Then tomorrow morning, the first 2 sessions, we will again split the team or the group in 2. We've got 40 registrations, so we'll have one group of 20. I believe some of you might be in the surgical training. I think 3 of you will be joining the surgical training tomorrow, so you will not be in the hands-on session. But as you can see, we've got a range of Oculus devices here for you to play on tomorrow. In the booklet again, at the back, you will see a sticker which will indicate whether you will be in the first hands-on training session. That means for the first 2 hours tomorrow morning, you will do hands-on on the devices. We have created sessions and tasks for you, and you will receive a booklet later today which will tell you more about the sessions. We've got 9 stations, so again on the booklet it will indicate on which station you will start, and we will rotate, but more info about that tomorrow. The other half of the group will stay with Kai tomorrow morning for the keratograph and binoptometer training. So we'll have a session 1, and then we will change 2 hours later, where the other half goes with Kai again, and the other half stays with the hands-on training. So, some exciting news. We will be launching a new feature on the Oculus Academy during this training. You're the first group internationally that we're launching this to, and we hope you will enjoy this. What it is we have now included open badges on the Oculus Academy. This is a feature. If you have attended all 3 days of the training, you will get the possibility to download this on the Academy and use this on your LinkedIn or social media profiles if you want to share your training history. So I would encourage you now, this is your opportunity to learn directly from the product managers and all of us here from Oculus. We're quite a big team here for the next few days. I want to ask you, take part in the sessions, take part of the conversation. We're all here to learn, and we want to learn from you, but we also want you to learn more about the Oculus devices. But most of all, enjoy this and enjoy getting to know everybody in this room. Thank you.
Good morning everyone, also from my side. My name is Jörg, and very happy to see this group growing and growing every year. So welcome to the training, and I'm very sure we will have a great time together. And Trisha, thank you very much for the introduction. And I just want to highlight one thing she was telling you and recommend to you. Try to be an active part of the training. You can ask us everything. So do not be shy, do not be worried. We are here for helping you. This is why we are here. So we work together as a team. So we are now, for at least a couple of days, part of your team here in Asia. So let's make the best out of it. Okay, the agenda for that day. I will do a recap of the Berlin ABCD, tell you a bit of the new Wave software. I have a video from Renato that he recorded and allowed me to share what he understands under refractive surgery today, because that's totally different to that what we had 10 years ago. Of course, competitors and hands-on. And also thank you very much that you fulfill the survey. Because only if we have your feedback, only if we know what you want to know, we can try to prepare the training content as fast as possible. So anytime when you have a question, feel free, raise your hand, and then we try to answer all the questions. I want to start with a very basic thing, but at the end that's absolutely essential. How to perform good PanaCam measurements. I know you install the devices, you're training the people, but sometimes some very basic things are important to recap. Everybody sees a problem? The problem is here. The lady, no, actually, that was no fingerprint. It was a lady who cleaned up everything. And she was very eager to do a good job. But unfortunately, not at the right position. So when you get these calls, QoS is not okay. I cannot get enough data. Your first question, right? Does everybody see the problem? The problem is here. It's a belt and the forehead. And see where the device is positioned. So what was happening? The old gentleman was afraid to get a measurement. So when the optometrist pushed the device forward, the guy pushed his head backward. Because of that reason, the professor of the university called me, Jörg, you have to come, the device isn't working anymore. And I asked 100 questions. But when I came there and arrived and said, hey, do a measurement, and I just want to have a look, I recognized this. So I took my lesson, and I want to share it with you that you do not run into the same issues, right? But this is so basic, you do not even think about that this is happening, but it is happening, right? So very easy thing, patient's position. The next thing, artificial tears before the measurement. Who thinks it is okay to put artificial tears on the cornea if you can't take a measurement? Hands up. Who think it is not okay to put artificial tears on? Hands up. I want to see it. Come on. And the rest isn't sure. Which is fair. And that's good. You know that we advertise with the PanaCam does real measurements and it does not need an intact tear film, which is absolutely correct. But when you look to another device that has any rings like Placido-based spoke before or any keratometer marks, they need a reflection, right? So, and maybe you have seen this next to the Ion Master, you have the eye drops, right? Good. Why? Because it is OCT plus keratometry. And for the keratometer rings, the two rings that the Ion Master has, they need a reflection. And especially people who have dry eye issues, they cannot get a measurement, so they put artificial tears in. But, and that's very important, we know that artificial tears reflect or influence patients' visual performance. With a bad tear film, it's like a dirty windshield, right? In the car, when you have a dirty windshield, you cannot see well, even if you are perfectly correct. And the same applies to a human being. But what is the reason why the optometrist puts on artificial tears? First, to get the measurement, and second, that the people can hold the eye open for at least 2 or 3 seconds, right? But when you have a dry tissue and you put, for example, cream on your hand, right? The tissue absorbs the liquids of the cream. And when we have some small wrinkles, starting in my age, sooner or later, the wrinkles go away. You look younger. But what happens to the cornea? Exactly the same thing. The tissue absorbs the liquid and it changes shape. This is a matter of fact, right? And as a consequence, then what you measure is not that what you have under real conditions. In other words, your keratometry can be off. But keratometry is essential for ion power calculation. Right? So, the consequence is, if you want to do it good, you treat the ocular surface disease issues first, and then do the measurement. Maybe you have heard about the Hill RBF formula. Who has heard about the Hill RBF formula? It's in the Hart Stride devices. It is developed from Warren Hill, a very famous and very smart doctor in the US. The first thing that he does, before he does any biometry measurement, and he does only cataract surgery, he checks the tear film. If the tear film is not okay, he treats the OSD problems first. So every patient gets something that he needs individually, and then he has to come back. And he doesn't give a shit if he comes 200,000 or 50 miles away. Before the OSD issues are not treated, he does not do any biometry measurements. And now you understand when you read his studies that he has 92% within half a diopter. The reason is he has good measurements. And he knows that. Why shouldn't we learn from the experts, right? So teach your doctors exactly the same thing. And of course, the doctors have to believe you, because they are the doctor and you are just the salespeople, right? So we have to find a way to talk to on eye level to them, that they respect us and that they believe in us, what you are telling them. This is a study that was done in the University of Vienna. So this is a very, at least in Europe, famous cataract surgeon. And he checks the influence of artificial tears. So he had 123 eyes of 80 patients. He divided it into groups for normal and for dry eyes. And then he took 2 baseline keratometry measurements, and then, as a second step, the group applied artificial tears. The astigmatism changed more than half a diopter in over 13% of the normal eyes. Of the normal eyes. No OSD issues, right? Normal eyes. And more than 34.4% in the dry eyes when they applied eye drops. So you see, that is an effect. And we have to be aware of this effect, right? So maybe you can use this study if someone is not believing in you. And on the other hand, some people may say, oh, this is not really important in my clinic. We do not have this in the region. I just looked a little bit to the study. I found one from Japan. 67 means 58.8% were diagnosed with dry eye problems before premium cataract surgery. So it is an issue. And this is even more important. When you have a patient that goes to the doctor and expects perfect vision because he or she put money on the table, so they want to have good vision, and especially when they get a multifocal toric or all this fancy good stuff that we have now available. If you treat it before, you are within a quarter of a diopter, which is a brilliant result, right? If you don't do it, you do the same thing. You do the same surgery, same IOL, same measurements, all the same. Almost double is the error that you have after the surgery. So it is really important to consider that before doing anything. And since my colleague Kai is much more deeper in that issue. He will now continue with the next slides.
Thank you, Jörg. Good morning also from my side. It's a pleasure to be here and to talk a little bit about the ocular surface disorders connected to the PandaCam measurement. So I would love to go back 1 or 2 slides again, what Jörg was presenting, because this is actually one of the latest research results where they point out that they have, let's say, around about 35% of dry eye patients, and they, among them, they have 0.5 diopters of offset. And this means, down the road at the end of that study, they told that either you treat the dry eye first, and not only for a second. That means just simply put some drops in the eyes to get a stable K-value measurement doesn't make sense at all. Because finally they find out after 5 minutes these measurements totally change. And so they said, as a conclusion, either treat the dry eye measurement first completely or leave it as it is. Because once you have an offset, or the surgeon has an offset of 0.5 diopter, no IOL lens will definitely correct that. And again, the results will affect the patient's visual acuity. But again, let's stay there. And I said I will bring up again, where is the ocular disorder, the main risk for which groups they have to be considered. And as you can see, the intersection here might reflect a little bit the most important areas. And as you can see here, we have, of course, cataract surgery. If you have not treated, or if the ocular surface is not treated well, the cataract surgeons will leave in a very heavy problem. And next step is the refractive surgery, and I will come to the next slides where we go a little bit deeper in that. Also, if the patient suffers from glaucoma, there it's needed to assess the anterior segment in terms of surface disorders. And also, if some of you also have already heard that the eyelid surgery also might affect or be the risk factor where the ocular surface disorders are very impressive to consider. So again, all these things, and let's stay a little bit for cataract and refractive, because this is one we are talking most in the PandaCam, and the intention was to sum up all which we have currently in the literature and stay at the refractive surgery. Here I've listed again the way in which you can currently proceed refractive surgery. So we have LASIK, general LASIK, we have femtosecond LASIK, PRK, and even SMILE. But the main thing is, again, they treat cornea. And once they treat cornea, they also affect the nerves. And once the nerves are affected, then of course it's a high risk to develop ocular surface disease. Tomorrow in the K5 session, we will get a little bit more in depth. We will learn a little bit more about the viscous circle in terms of dry eye. But again, once you destroy, or at least cut some nerves, patients will suffer from dry eye, for sure. The second step, the second column, are the cataract surgical ways. Standard cataract surgery, also FLACS, femtosecond laser-assisted cataract surgery. We have also the SICS, or even CMIX. I think everybody of you has already heard about that. I don't want to go in depth, but again, probably, obviously, the corneal tissue is cut, and once again, there is an influence there. And you have to be aware that the ocular surface is treated well, so that at least you'll be aware that the patient don't suffer at the end from another disease. And of course, OCD is a disease. We will get a little bit more learned about tomorrow. Glaucoma as well. We have here some open-angle glaucoma cases. Trabeculectomy, when we cut the trabeculum, and at the end we have also some eyelid surgery again, which is not that, but it could also be affected once you do not treat the risk factors. So let's stay at the refractive surgery part, and this is very amazing because all of the studies which show that post-LASIK, the dry eye usually peaks in the first few months after that surgery, And then the symptoms begin slowly to increase, and the majority of the patients, even after half a year until 1 year, is suffering from dry eye. And again, this is published officially in 2011. You should also continue with the second part, like the tear functionality was tested, and they found out that they compromised after LASIK in patients with dry eye compared to the patients without, and that is a very official point where we can of course check and which have to be done, and this is what was Jörg telling. I would love to see that we have more doctors checking out the tear film before any type of surgery to be aware that the patient has to be warned that once they have already a dry eye, it could be getting worse, or even that there could be a side effect once we do any type of surgery. Here, pre-existing dry eye, this is what I was recently mentioning, is the most significant risk factors for developing severe dry eye. This is also, I think, very clear, and patients with pre-existing dry eye symptoms should be warned that it could be worse. And once talking about ocular surface disease, and all of you know that we are talking mainly about signs and symptoms. And for that, we have so-called clinical signs and symptoms, and especially for refractive surgery, you will find, of course, the early beginnings, the early stages could be that the eyes are irritated, the patient's telling us about burning and dryness, and even if you go worse and worse, the next steps will be the hyposthesia. That means that the cornea tissue is not that reacting any longer, that they are very heavy, long responses, so might could end up in corneal epithelialization, and as you might see here with its highlight in yellow, chronic inflammation. So again, the inflammation part is one of the most impressive point, which have to be considered after LASIK. This might end up then here if you use fluorescein dye, stain the cornea, check out whether we have an overall staining pattern like this, and independently whether we see glycerin green. But the point is, as you can see this, that it's way too late, because again, this corneal staining means we have to care about the cornea any longer, of course, in order to stabilize that issue and to get a brilliant visual acuity later on. And this might, and at the end, we have also, in the worst case, the loss of corneal sensitivity at all. Again, this is the worst case, but in the first three ranges, this is something we have to be, or you guys have to know that, because some of the refractive surgeons don't care about the anterior segment, don't care about the tear film. Let's go ahead with the cataract surgery, and just to sum up, you will find here the most impressive part. Pre-existing dry eye is a significant risk factors for persistent dry eye after cataract surgery, which again can be worsened after the surgery. And this is something we have to consider, even though that we have here the point, several parameters occurred 1 week after cataract surgery and could stay even from 1 month to 1 year. And this is something with a high variation. But again, even though independently how the cataract surgery was performed, it's needed to assess the anterior segment, the tear film special. And to sum up, we can see here on the right side, this is a quite interesting theme, because before we have some influencing factors here on the left side, and they could lead to the point that the reduction of some cells in the cornea, corneal denervization, and then lead to the cascade that the patient develops a dry eye. So here you will see the homeostasis means that we have a potential equilibrium, that the patients have some sort of pre and post-operative risk factors have to be considered. It's very impressive that patients diagnosed with dry eye disease worsened, report a worsening of the symptoms. Again, it's needed to update them before the surgery, and also, which is mainly the most reason to cancel the cataract surgery, is the blepharitis. And if we see here and sum up all that single parameters, like for refractive surgery, checking the symptoms, checking also ocular signs, as we can see here, and even for the cataract part, checking the ocular surface, the tear film stability, and also the dry eye parameters, subjective symptoms needs to be done in once. And now the question for you, which device we could do this best? Right, thank you. The K5 with all the functionality with the Genius Pro software, which can not only capture the images but also address exactly which parameters are very suspicious, especially if you do the staining, as you can see here. Everything with the parameters coming from the Deuce 2 workshop, which tells us which measurements need to be done, could be set with the K5. And luckily we have also with the software the ability to grade them. And this is something I would love to see, that more and more doctors see that and address that prior to go ahead with the surgery. That said, I want to hand over to Rick again. Thank you.
Thanks, Kai. Let's make it a bit more interactive. This is a poll. You see the code over here. I'm not sure if you can see it or if I have to make it a bit bigger. Let's see if it is working. So I hope you can scan it now. So please, everybody, this is a bit of a recap what we just have learned. Can everybody get a photo? Is this okay from the distance even? Okay, so come on, move your body, get a bit in motion, come in front, take a photo if this is not working. Yeah, otherwise you are going to sleep and this is not what we want, right? Come on. I want to see everybody giving a response. Okay, at least we get the first one. Come on, guys. More than one answer is okay. Okay, looks good. Come on, guys. The good thing is nobody sees your answer at the end, so perfect, right? No worries to be off. Very good. Come on. Okay, I want to see some more responses. Yeah. Ah. You are getting in motion, guys. That's good. Okay, come on. Don't be shy, nobody sees your answer. And we do not even record it, so it's okay. Everybody replied? At least some are looking very anxious in their smartphone. Come on, don't be shy. And up to now, I'm really happy to get this response. Of course, some patients cannot hold their eye wide open. But this is a side effect. we need to get stable measurements, which is a basis to have a good outcome, right? And of course, if we talk about corneal refractive surgery, we want to have good vision. Thank you. If you want, you can take a photo as a recap and take it home. Good. Okie dokie, let's change topic. That was kind of an introduction when we talk about refractive surgery. I want to come back to a unique selling proposition that you have in PanaChem, which is a Bayesian ABCD staging and progression. Why is progression so important for keratoconus? Why is progression the most important part? Any idea? Who? To whom do you point, Trisha? To you.
Bayesian ABCD staging progression for see the corneal progress sustained to see the progression of after the LASIK surgery or cross-linking to see the progression how the cornea gets stable or not.
Perfect. Memorize the last sentence. To be sure, after cross-linking, if the cornea gets stable, you have to, not you want, you have to check your success or not. And before we come to the treatment, we have to make sure before we do any surgery, because it's an intervention, it's a surgical procedure. It is not just putting something on your cornea, it is a surgery. And before ethically we touch the patient's eye, we really have to be sure that there is a progression. Okay, think about glaucoma. Glaucoma is exactly the same thing. Imagine you have a device that is telling you, oh, this patient has a risk for glaucoma. Okay. So what is your next decision as a physician, as a doctor? What do you do when you see that in a patient? What are you doing? You monitor it. That means, depending to the severity of the disease, you ask the patient to come back. Because you want to see, is there progression? So now let's look to this point from a sales perspective. A device which just tells you you have a problem does not help you. It's like we all have in life thousands of problems. And we do not want to have another one on top. We want to get solutions, right? So the doctor is exactly the same. A device which just tells him, oh, this patient has a problem. Okay, another problem on top, right? But if he has a tool where he knows, okay, this software tells me when the patient comes next time, I can compare the first measurement and the second measurement. And then I need a criteria which is objectively telling me and the health insurance, because somebody has to pay for this stuff, right? There is severe progression or hopefully not. Okay, from a sales perspective, there is the iStar 900 from Hackstreit, right? A very cool device. Very smart development from Hackstreit. They have in a new software which will be launched, I don't know, maybe at ESCRS, a new display. So don't be afraid if you see it, I tell you before, that has the ABCD staging. Guess where they get the data from? Copy-paste from the literature based on pentagram measurements. That's your first argument. And the second argument, they have no progression display. So now, when it comes to the discussion, and somebody tells you, oh, the iStar 900 that has a great tool to create and stage keratoconus, you can say, yes, this is nicely copied from Pentagram. And your second argument is they are lacking about a progression tool. So you see, when you go against competitors, it is not saying, oh, this device is not good or whatever. No. Really talk basics to them. Why is our device better? And if you have good arguments, then you can sell it. So you have to understand why it is needed, right? Early detection. What does early mean? In the age of 5, 6, 7, 8, 9, 10 years of age. Kids, children. This is early. Not with 22, then it's too late. What is your consequence? Every eye doctor who sees children needs to have a pentagram. Right? For screening. They want to detect the disease. And you have to treat it as early as possible because you want to preserve vision. That's the most important thing. The young kids have a high risk for progression, the highest risk. Early detection is the key, and the objective determination of progression. Because you have to make a solid decision. And let's focus a bit to this population, to kids. Kids never go alone to the doctor, their parents come with them. Of course, right? They care for them. So, not the kids have to understand the problem, the parents have to understand the problem. Right? So, I can tell you many, many things. I can talk to you about an hour and then you scratch your head and say, what does this guy want to tell me? If you show them a picture, a display, a screen, they gotta understand it, right? And you know the bars and the progression display, right? The longer the bar, the better it is. The worse it is, right? Everybody understands this. No need to go to university, right? So make it visually understandable. And then, when it comes to the decision that you treat these young kids or young adults, you need a post-op control. And you know the Berlin ABCD progression works after cross-linking as well. This is a unique selling proposition. For you as salespeople, the most important arguments, but not only telling, hey doctor, this is your need, you have to tell him why he needs it, right? What is the benefit? And the Pentagram is the only answer. Perfect. I want to do the next thing, which is, I think, very important to understand. My mouse is working. You know we have two displays. We have the Berlin Ambrosio Enhanced Ectasia display, and we have the Berlin ABCD. But what is the difference between the two? This is very important to understand. So please, take a photo and take part of the photo. We got one response, 2, 3, 5, 6, 7. Okay, come on guys. And the boys in the back row as well, come on. Don't be shy. This is a nice control if you have understood the e-learnings. It's part of it. Ladies in the back, please, come on. Take the photo, take part of the poll. You can stand up, it's allowed to walk around, right? It's not like in school. Very nice. Come on. Most of you understood the difference, and this is very important. I see, unfortunately, too many studies which are using the bad D to monitor progression for keratoconus. This is when I could start crying and say, hey, you did not got it, right? The bad D separates normals from abnormals. It tells you you have a problem. Maybe I have a problem now. Okay, good. Some problems you can fix. So when you explain the device and when you explain the software, make sure that the people really understand for what a specific piece of software is good for, right? We all know the Belin ABCD enhanced dictation is mostly used to screen for refractive surgery because this is one of the big strengths. But what else can you detect with the Belin Ambrosio enhanced dictation display? You can detect Fuchs endothelium dystrophy. Do you know how? Do you remember that part of the Belin Ambrosio display? This is normal, right? And if you have ectasia, the curve is like that, right? So how is the curve for Fuchs endothelium dystrophy? Perfect. This is Fuchs. Because the cornea swells, right? The endothelium cannot pump the water out, so the cornea is swelling and swelling and swelling. So you see, this piece of software has more than one application. And what is one key thing when you want to sell equipment and software? You have to surprise your customer. They say, now I got it. Because what do you do as a potential purchaser? You have to list what you want to get, to receive. So you make check marks. Got this, got this, got this, got this, got this. At the end, a price. But if you can add more to the list that the surgeon or potential buyer really needs, the chance to sell prices up, right? Good. So thanks for this good response. This is a summary of that what we did before. Okay. Next thing is a bit of science. If you tell something, you have to prove it. Otherwise, people have to believe. And faith is something bit difficult. Das wieder richtig. Okay. The Berlin ABCD is based on the global consensus. A global consensus means you collect experts, lock the door, and let them out when they get a conclusion. Frankly speaking. Because if you ask 10 experts, you get at least 15 opinions. Why am I saying this? If you have such a study where global experts from all over the world agree on something, it is fundamental. It is the standard. There is no excuse to do it different. It is the standard of care. And that's very important. Cited by almost 1,000 other authors. Almost 1,000. This was last week. This is one of the most popular studies which came out in the last 10 years. It tells you the importance of this study, right? Because all other papers related to this topic refer to it. On the other hand, the standards which are described there have to be used when you deal with this issue. A very important argument. It is not just an opinion of a single physician, and that's important to know. Here, there are the definitions. Agreement reached in the definition or diagnosis. Abnormal posterior elevation. So, anterior surface-based devices outdated for that purpose. Abnormal corneal thickness distribution. Distribution means a graph like this. Distribution means not to tell you what is the sinus pachymetry. Why am I telling you this? We have other tomographers in the market who shows you pachymetry. And they tell you what is the sinus location, what is the corneal thickness in the pupil area, and they tell the buyers, well, you can use it for keratoconus. And the physician say, oh yes, this is great. But you miss the important thing, because it does not reflect the standard, right? So when you are in these discussions, and if keratoconus is an important part for the prospective buyer, remind them, refer to the study, buy it, invest the $40, right? Have it with you. Refer to it on your website, that everybody knows this is important. And posterior corneal elevation abnormalities. How can you detect abnormalities if you know what is normal? Right? Easy like this. If you don't know what is normal, you cannot tell what is abnormal. And the pentacam is clearly defined, and many studies support this. Ectasia progression, steepening of the anterior corneal surface, steepening of the posterior surface, thinning, and or the increase in the rate of corneal thickness range. Unique to pentacam, right? And coming back to this new potential group of buyers, the doctors who deal with young adults, you offer them a pentacam basic if money is the issue. The Pentagon Basic with the basic software has built-in ABCD staging and progression. You are good? Not a big investment, not a big deal, but you save the place for Pentagon. No other device go into this office in the next 10 years. Yeah, you secure the place, and that's important. This is a nice paper which summarizes the whole approach. Building on also enhanced dictation, building ABCD staging and progression. A paper published in Cornea. I recommend you to read it and to share it. Written by Michael, his fellow, and Mark Rockström. He did the stats. Good. These are your sales arguments. What is important with sales arguments? You have to have them here. Right? Here. Present. In the very moment. If I wake you up at night, 2 o'clock, and ask you, what are the main sales arguments? You have to say, bum, 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 right? You have to learn them first by heart, and second to understand how to use them. Very important. E-learning platform has it all. The next thing is, you go to the doctor, telling him about the great tool, about keratoconus and how important it is, and he tells you, oh, in my region, the prevalence is low. Well, many people thought this. The first study, I think it was published in the 16th, 1 out of 2,000 has keratoconus. In New Zealand, guys, for you, right in your region, 1 out of 84. 1 out of 84 in the Kiwi population. In America, 1 out of 334. In South Brazil, 1 out of 137. So you see the prevalence is varying, but the prevalence is high. And maybe in your country, such a study is not yet published. Many doctors need to publish papers. Why not telling him, okay, I give you the device for 2 weeks, 3 weeks. Go out, collect, publish. I promise you, he will buy. Right? And you have this study for your region that you can prove here. It is important. These are your take-home messages. If you want, you can take a photo. If it helps to memorize it, you have the mobile with you any day, every moment. Even to put it under the pillow to sleep better. Maybe that helps, that it penetrates. I mentioned the iStar 900. You have many arguments to go against this. I mentioned 2, right? Based on Pentagon data, and they have no progression. But the good thing is this one. If all the data are based on Pentagon, this is your best argument to sell your device. Why buying another device which is using data from another device to put in the software? So turn a sales argument from them into a sales argument for you. It is easy if you understand the topic, right? And don't be shy. You can do that. And it increases the awareness of the spelling ABCD. We had 4 months ago a meeting in the Arabic region, an official general ophthalmology meeting. 85% of all the lectures were related to keratoconus. More than 60% of the presentations were related to pentacam and quartz. We did our job, our distributors did their job. And it turns out, right? You have to prepare the way. But then it runs from itself. Progression analysis, I think is key. Any questions before we change topic again? All good? Sally is offering solutions for known challenges and even for yet unknown challenges. Why am I adding this? When you do an investment, do you do the investment to solve your problem that you know? Or do you want to prepare for future challenges? You want to prepare for future challenges, right? This is what I mean when I told you surprise your customer. You have to tell them something which they are not aware of, and not telling the problem but show the solution. Then the risk, then the chance increases to sell the devices, right? Okay, our field is refractive surgery. What is meant by refractive surgery tonight? Not tonight. Today. You see, I like quotes. It's my latest topic. I do it even at night. Guys, come on. Well, it's at night in Germany, so I apologize. More than one answer is okay. Okay, you are getting in motion, guys. Come on, I want to see a response from everybody. Okay, please, take part. Okay. Come on. Okay, so the first option, corneal laser vision correction, I think this is clear. This is what we understand under refractive surgery for many, many years. Implantation of spherical IOLs. Is this refractive surgery? everybody knows what a spherical IOL is. This is the cheapest thing you can buy in the shop next door. This is not refractive surgery. This is standard cataract surgery, right? I think implantation of multifocal IOLs, this is refractive surgery today, right? Implantation, well, thank you for giving me some more responses to that, I like that. Faking IOL implantation, this is refractive surgery, right? Is corneal cross-linking to stabilize the cornea refractive surgery? Corneal cross-linking to stabilize the cornea. Is this refractive surgery? I think it's a bit controversial here. Let's leave it open. I think implantation of EDOF IOLs is clear. Treatment of ocular surface diseases is not directly refractive surgery, but it is a prerequisite to do good refractive surgery, right? Why am I doing that? Because sometimes the borders are not clear. So we cannot say this is that and this is this, right? We have kind of an overlapping. If you understand cross-linking to stabilize the cornea to preserve vision, okay, then I understand it's refractive surgery because we want to preserve vision. If you understand it in treating a disease, then it is not refractive surgery, right? So we clearly have to separate between the two. And maybe in different countries you have a different understanding. Okay? But let's try to stay on topic, please.
I think my definition of cross-linking is that you can't dial in a refraction, and that's a big sort of thing for me, is you can certainly halt things and halt progression, stabilise things, but you don't always know the outcome is going to be refractively afterwards. That would be the common thing for me.
So you see, as he mentioned, it depends on from which perspective you look to things, right? Okay. What I want to focus today during this session are these topics. Corneal laser vision, phakic IOLs, EDOFs, and duet system. Has somebody heard of a duet system? Do you know what a duet system is? A duet system means you implant two IOLs. You implant one IOL in the capsule, and you implant a second IOL behind the iris, like the ICL, like a phakic IOL. So this is a reverse solution, right? If the patient does not tolerate the multifocality, you just take the phakic IOL out, right? And you leave the normal aspheric toric correction in the back as usual. But it's a combined solution, especially for younger patients, or for patients where the doctor is not quite sure if the patient really tolerates it, but insists to want to have or to be spectacally independent. So,
and many others. My topic today is aphasia screening for refractive cataract surgery. Why, how? This is my financial disclosures. And when we think about refractive surgery, definitely including refractive cataract surgery, it goes beyond the cornea to less dysfunction. A nice concept described by Jorge Aliol, then Barry, George Gordon Ford, and others. And the future of refractive surgery goes beyond the cornea, definitely intraocular with phakic and pseudophakic lens replacement. When we think about the difference between a standard cataract surgery and a refractive cataract surgery, in one word I would say it's planing. In two words, it will be refractive planing. So how we do that? We do it with multimodal corneal imaging. We have topography, tomography, segmental tomography, biomechanics, and it goes beyond the cornea with exo-lens and whole eye wafer. And eventually goes even beyond imaging with molecular biology and genetics.
He lost his voice. You understand? This is how a corneal surgeon, a former corneal surgeon, understands refractive surgery today. It is not the opinion of me. It is the opinion of the guys in the society. Why not using it? Scan the barcode, put it on your website, share it, right? And your sales argument was written or was shown there. Multi-modality imaging. Pentacam, Kellerluftgraf, Cordis, Binoptometer. The devices we have over here, right? Why is this important? Again, a doctor wants to have a solution for his problems. And we offer him everything. So try to sell the whole range and make your selling concept around. Yeah? Do not stick with one device. It is more than just it is more. A lot of problems or a lot of challenges. I would say a lot of opportunities. And remember the word opportunities. Turn a challenge or a problem into an opportunity for selling equipment. There is no need to teach a doctor about this. They know, even better than us. They have it every day. So, once more, when you go to a doctor, you can tell him or her, okay, I have a solution for this, for this, for this, for this, for this, and for that. Okay. Then you check in the clinic. What do you have? Outdated or new stuff where you cannot really argue, okay, let's make the story around. This is selling, right? You need to know what your doctors need. You need to know what your doctors, what your potential customers need, and offering it to them. And don't be shy with it. Next step. Oh, your device is so complicated. So many displays, so many possibilities. Oh, and the list is so long. And I have no idea where to click. Poor training. Sorry. Poor training. This is your job, guys. This is your job, not mine. This is your job. If you do not properly train the high class and high price equipment that you want to sell, you will have no success. I signed it. It is your job. Your customers have to understand the benefit of the software. absolutely essential. And there are different ways doing that. I like the KISS strategy. Do you know what KISS means, besides kissing? Keep it simple, stupid. Keep it simple, stupid. Or make it easy. Because it is easy. It is not difficult. It is difficult as long as you do not understand what you are telling them. Then it's difficult. But if you understand what you want to transfer, if you understand the message that you want to transfer and the need, then it is easy, right? Then it's simple. If you have the Pentacam AXL and you see, I put OSD assessment as one important part. You can do with the Pentacam AXL, for example, the step-by-step approach. And the Pentacam has, I think, 24 different displays, or maybe more or less, not sure, forgot the number. No need to explain everything. Explain the most important ones. That's fine. And you know your customers have an EMR system or a printer. And you know that you can configure a list in the software, yeah? That the doctor only press print or store or export, and then all the important displays automatically printed or transferred to the EMR system. You have to do that with the refractive managers. You have to configure the list together with them. You do the job. The optometrist will never do it. He has enough to do, right? Your job. With the wave, you see the fast track is even shorter. 2 displays, not more. Then you can cover almost everything. What does it mean for you from a selling perspective? You save time. Time is money. And you save space. I visited once a doctor, and for one patient, he has 12 printouts. 12 printouts on his desk. And I was surprised how he is able to manage that. I would be totally lost. I showed him the new full sequence overview display. And I told him, you get rid out of this, out of that, out of this, out of this, out of this, out of this. You need that. That's all. He bought. He purchased the device. Why? I did not only show him the equipment. I showed him how to use it. I explained how to use it, how to utilize it. This is an important thing for you. Not learning the manual by heart. This is shit. No, sorry. This does not help you for selling. It's mandatory, absolutely mandatory. You need to know where to click and what to get. Selling is more. You remember that from Kai? All is there. Oh, it is so long. And it is so complicated. I don't want to do it. I know this argument. Maybe you have heard about Professor Auffert, Gerd Auffert. I think also well known here in the Asian region. It took me 5 years to convince him to use a Keratograph 5M. Even it is not my baby, it is more Kai's baby, but we placed it in the hospital. And I always told him, please, take a look, use it. Yeah, Mr. Ivanchuk, you know, this takes so long, and we have so many other things to do, and then the optometrist is sick, and I have to train another one, and then the whole schedule gets messed up. 5 years. One day, when I was sitting together with him, he told me, can you tell me the reimbursement codes for ocular surface disease screening? I said, after 5 years. What was the driving point? Yeah. Money. But not everything. Then he told me, oh, I'm considering buying an IPL system. You know an IPL system? And I have to make a reimbursement plan for the hospital to justify the purchase. But I think, with my amount of patients, 9 months. I'm pretty sure they will accept. He bought the IPL system. He is using the Kertograph 5M for every patient, prior surgery, after surgery. Guess how long it took him? How many months to get his money back? 3 months. An investment over 100,000 euro. 3 months. It took me 5 years. Be patient. Be resistant. Don't give up. It pays off the efforts. We had a lecture at the ESCRS Winter Symposium, Ocular Symposium. Guess what he was showing? Cases. OSD screening prior cataract surgery. Then doing cataract surgery. And controlling afterwards. When patients come back and say, oh, I don't see well. What do you do as a physician when the patient comes back after surgery and says, I don't see well? That's exactly what you do not want to have, right? It costs hours. Hours to do the measurement, to talk to the patient, calm them down, justify what you do. You have no time for that. Because in this time you can see 5 other patients minimum. And he showed it nicely. I examined the patient with a Kertograph. And I could clearly show him, the problem is not the surgery. The problem is your OSD problem, your ocular surface disease problem. I gave him the right medicamentation. 4 weeks later, I did again an examination and I showed him prior, after. Compared to patient's vision, patient was happy. You see, it is not the investment only, it is a success. And you have to tell your prospective buyer these stories. They understand it, right? When they don't see the investment, they see the benefit, right? This is important for selling equipment. You know that fast screening report? Nothing to teach about. The most important parameters to screen for. By the way, what is TKC? What is TKC? Topographic. Okay, do we need that? Do we need that? When we have Berlin ABCD, when we have Berlin also, do we need TKC? Who votes for yes? Who votes for no? And who is not sure? obviously the rest, right? Fair enough. TKC describes you have a problem on the anterior surface, correct? Is a problem on the anterior surface always related to keratoconus? No. Not necessarily. Keratoconus starts on the posterior surface. Why is it good to know that? Ocular surface problems. Change shape on the anterior surface. Corneal scars. Change shape on the anterior surface. Any intervention on the anterior surface is recognized by this. It is useful in the right perspective, right? So once more, when you talk about the display, do not explain only what this parameter means. You have the help text, it's easy anyway. Explain why the doctor needs it. Then he will look to it. Otherwise he will just forget, right? Parameter, benefit. Parameter, benefit. Display, benefit. Important. I think this is known as well. Are you teaching the meaning of this button? What does this button mean? Another database for hyperloops. Teach it. It's important. Because otherwise you rule out patients. And you never want to rule out a patient. Corneal optical density. Unique. Unique to Pentacam compared to all the other competitors. How can you use this display? For which purposes? Huh? Fuchs endothelium dystrophy. What we're seeing over here, right? So you have an opaque surface on the posterior side of the cornea. Why is the detection of Fuchs endothelium dystrophy important prior cataract surgery? Why is it important? Yeah, you lose endothelium cells during surgery even more. But why is it important to detect Fuchs endothelium dystrophy? Besides the disease itself. Two things, at least. It is a progressive disease. It is like keratoconus, it's a progressive disease. So if it is not treated, it progresses, and at one point you have to do surgery. So you remove the endothelium and you put an implant on the posterior surface of the cornea. Now imagine, for cataract surgery, why is it important to know that prior surgery? If you know the history, how it is progressing, and what the surgical intervention is, if you put something to the back of the cornea, what do you change? The refractive properties of the cornea, correct? Now imagine, you have given that individual patient a good IOL, toric EDOF, toric multifocal, whatever. And the patient is happy. The latest, after 3 years, he comes back with severe Fuchs endothelium dystrophy. Because, like you mentioned, during the surgery, it just gets worse. It doesn't get better, it just gets worse, and it progresses faster. And then you do surgery. The good thing on the surgery is you can stop usually the progression of the disease. The bad thing of the surgery is the patient gets hyperopic, which is a killer for every IOL power. You can be a bit more myopic, typically, that's forgiven, but never hyperopic. Then the patient is not very happy anymore. He puts money on the table first, right? He pays. And 3 years after, he has to find out it could be done better. This is a story to sell it, right? What else can you see in this display? Remember Trisha's e-learnings. What else can you see in this display? You can see the layers, yes? I can't hear you. And the rest of the problem.
To see the doctor after flapping, to see the millimeter of the
Thank you. You can see a flap. A flap after LASIK. So, before premium cataract surgery, every patient has to go through a questionnaire. Do you have any severe dry eye problems, surgeries, whatever more? And did you have any previous eye surgery? Is LASIK a surgery? No, it is a refractive procedure. Done next door. They do not mention it. And then the IOL power calculation stuff. If you don't detect it. In this display, you can see it. And the next good point that you mentioned is you cannot see only the flap, but you can measure the so-called residual band thickness. Do you know what the residual band thickness is? It's a corneal thickness under the flap, right? So when you lift the flap and then measure corneal thickness, this is the residual band thickness. Why is this important? Well, if the surgery goes wrong, easy like this, and you have to do the LASIK on top, because you do not want to explant an IOL. A 5-minute LASIK is much more quicker and cheaper at the end of the day than explanting the lens and implant the lens. But you need to know, do I have enough tissue back, right? So it's important to screen this before premium cataract surgery. These are sales arguments, right? It is not just, we have a nice display, and by the way, it is unique. And then the doctor says, and? Why? For what? So, display, application, solution for problems. I think this is a standard display. I think 100% of all the doctors are using. And they use it mostly for this, and for that. Is a cornea normal? Do we have any ectasia, or can I go just straight ahead with surgery? You can use it for much more. What is this? This is a posterior elevation map. What does this map show you? Speak up. Astigmatism. It's purely astigmatism. Easy. keratoconus, right? This is obvious. Why? Because you have plus numbers. Means you have your reference and the cornea is above the reference, right? This is why you have plus numbers. Make sense? This is Fuchs. Exactly the opposite of keratoconus. So you have minus or cold numbers, right? Blue. It's the same pattern, but different numbers. And you see the pachymetry map totally lost its regularity. Thin in the center, thick in the periphery. Why? Fuchs is a swelling of the cornea. So here is your reference, and your cornea is below the reference because the posterior surface is swelling, right? So it is minus, it's below. Does it make sense? Yeah. So the Pentacam gives you almost everything to detect almost every problem or everything that can be a problem after the surgery. To know it prior, to consider it and to treat it properly. Right? And by the way, there is a demo patient. It is called Fuchs endothelial dystrophy. You can use it to show that. Flap. And for those of you who have underwent or who have taken part in more than one oculation training, this is one of the clinical cases that you trained in the past, right? The refractive surprise after cataract surgery. Because it was overlooked. Yes, please.
Is there any data?
Just wanted to know if there's any data on how long the flap will stay evident, so that we know is it fail safe? It's always going to pick up a flap. Yeah.
There is no study published from my knowledge. So typically, as long as the interface is reflected, and this is typically during the whole life of a patient, you can see the flap. Typically, when you have opacities below, you can treat with some special drops that goes away. But the rim remains. Richard?
Also, the type of flap that was made, microkeratomes versus a femtome. Microkeratome becomes even harder to see.
Yeah. But if you see it once, you see it forever. Okay. Your standard display for cataract surgery, guess everybody is aware of. And please teach it. Teach it. This is the important part. E-learning. An e-learning card, if I'm not mistaken.
We've got a video about the cataract relapse today and also the Pentacam cataract certification course that goes completed for 6 hours.
In doubt, if you are not sure, before you visit a customer, go to the platform, look to the video again, write down the most important things you have in the video. Do you see the flap? The rim of the flap? Yeah, if you know, then you see. If you don't know, you overlook. Easy like that. Same patient. Right? Okay, any questions up to that point?
wave you removed fast screening? I'm curious why you decided on one.
The reason why we built in the fast screening report was to show abnormalities. In the full sequence overview display, you have almost all the parameters that you have in the fast screening report color coded. Right? So if it is yellow or red, it is out of normal limits. This is the argument for me, one, and second, you save time and you save a display to look to. This is my strategy. If your strategy is I'm always focusing to the fast screening report, stick with it. And remember, the full sequence overview is only available in the Wave. It is not available in the Pentacam AXL. So it depends on which device you want to sell, where you want to put your focus on. If you don't, or if you are not able to sell a Wave, then you go a different strategy. If you are able to sell a Wave, and the doctor was using the fast screening report before with the other device, you know you sold this to him, right? And if he likes it, don't take it away. Don't take something away, just give something on top. And let the doctor decide, right? And this is a problem when I show a strategy, because it is my strategy. It's our strategy mostly. And it's up to you to adapt it. If you adapt it, you need to know why you adapt it. Not only because a trainer from Oculus told during the training you have to do it. This is nonsense, right? If you decide for yourself, I feel comfortable teaching this strategy, do it. If you think for us in my country, or for being me successful, I use another display, hey, do it. Right? But that's the reason why I took the fast screening away. It has its benefit, but if time matters, and if you know it is a busy clinic, then you can skip it. If you have a chance, of course, focus on it.
So one more question that I always get out there, and this kind of combines the first part where we talk about the ocular surface, keratometries, and also the refractive part. What about doing dilating drops? Changing keratometry or not? And also, does it change the overall IOL calculation or not?
Very good comment question, Richard. And I think this is also related when we talk about patients who have glaucoma. Glaucoma eye drops dry out the cornea. All glaucoma patients treated with drops have ocular surface disease problems, because the drops destroy the ocular surface. Okay. Drops to dilate the pupil are liquid. A dry tissue absorbs liquid. It's exactly the same approach, right? It changes shape. So do not dilate the pupil if you want to use the measurements to calculate the IOL power for the lens. Okay? Other questions, comments? Something to add? Then I recommend to make a 15-minute break to refresh your memory. Have a tea, a coffee, whatever. I hope it's prepared outside. And then at, let's say 10:50, we move on, okay?
过不去没？ กินเกี๊ยวทอดไหมเกี๊ยวทอด
คุยได้หรอก็ที่เมื่อวานนี้ที่เรากินตอนดึกอันนี้คือเสียง
นาเบลโอ้โห
มีมันม่วงแล้วมันฝรั่งแล้วก็มันหวานเปล่าที่มาจากญี่ปุ่นที่มันโปรตีนต้องฟาร์มแต่ว่าอันนี้
ลองกินมาดู
worst case 2 ห้องนี้อาจจะต้องจ่ายนะฮะ worst case พูดเล่นเดี๋ยวเราซื้อตามไปซื้อกันดีครับ
คือบริษัทเราจ่ายหรอ
นะ
บริษัทเราจ่ายหรอ
ไม่หรอกคือซูซานเขาไปลงแค่ห้องเยี่ยมเดียวแล้วทีนี้อีรีเซพชันมันก็อยู่เวย์อยู่กับอาสมาแล้วก็เหมือนเปิดห้องใหม่กันประมาณนี้
ก็นอนยังไง4 คนห้องเดียวกันพูดไปเรื่อย
นั่นแหละกี่ห้องเลยอยู่ในนั้น
พี่ต้องพูดว่านอนระเบียงน้องเราอ่ะดูแล้วเดี๋ยวเราไป
มีขนมอะไรกินไหมข้างนอก
มีไปดูไหม
ไป
ไม่เขาไม่บอกไม่ถูกกูว่าแล้วระบบดูล้วนๆเมื่อวานระบบอะไรระบบพนักงานดูล้วนๆ
three. Perfect. It's easy to get the people out, but it's even harder to bring the people back.